fantastic guest speaker. So Rathai Thevananth is both understands this topic and is also an operational practice manager. So very much sees this through the same lens as yourselves. We see the session very much as helping you navigate from where you are now in terms of your understanding of CQC to where you need to be to understand the single assessment framework, both for you and your organisation. Rathai will be your compass to give you direction of travel, and if it's a detailed map you're after, then compliance-wise, that's a product we offer called FPM Core. And if you think the change will introduce some training needs for you or your team, then we'll also put a link in chat to do with Thornfield's training, where you can find out how to bridge those gaps or fill those gaps.
My name's Rathai Thevananth. Thank you very much, Joey, for the introduction. I'm a practice manager, as Joey's mentioned, and I also do inspect with the CQC. And today I'm obviously presenting as a consultant. So do make this session as interactive as possible. Do feel free to put questions in the chat, as well as unmute and ask questions. We have got a 15-minute question and answer session at the very end, but happy to take questions as we go along. So let's start. Right, so the why and the when. So we've got the new single assessment framework, which has been rolled out this month, well, November actually, in the south of England. And the plan is for the rest of the country to have the new single assessment rolled out by March 2024. Now, the reasons for the new single assessment is because we want to have a much more shorter, easier to read report, rather than the lengthier report that was there previously. We'd like a single assessment framework, not a multiple framework, and we will talk about this in a lot more depth later. And the regulation will be on an ongoing basis and not from just one site visit, as well as inspection team assigning scores to the evidence they find on a scale from 1 to 4. So there is a new scoring system as well. So the framework will be the new policy for all service types, whether it's a large hospital or a small GP practice, and it's for all levels. So there'll be a new way of organising. So primary medical services inspectors will be inspecting GP practices, and they will also use other specialist teams when they need to work in a much more integrated manner, but also sharing intelligence. So a lot more integrated process there as well. So if you see here, this slide will just tell you the regions where the CQC will be rolling out the new single assessment framework, and they get normally 2 to 3 months notice. Obviously, the south has begun, and these are the list of ICBs here you can see are those in the south. And that started already from November the 21st. Between 21st of November and the 4th of December, the CQC will then undertake a small number of planned assessments with early adopters, and they'll continue to respond to risk at the same time. So going to the next slide, you'll see that from the 9th of January, we've got the London and the East region being covered. And then from the 6th of February, you've got the North and the Midlands region being covered as well. The actual ICBs, if you want to be listed, they are on the CQC website, which has been updated on the 5th of December. So you can see the actual ICBs which are being inspected if you want to go and check which one yours falls in, obviously. So just looking at the comparison of the changes, so you'll see here from the previous framework to the new framework. So one of the most notable changes is the introduction of the scoring and the quality statements and the key questions. So this doesn't mean that the rating system is being abolished. It's staying the same, but it will be supplemented by a new scoring system. Another interesting shift is the move from a detailed narrative inspection report to a shorter report published on the provider's page on the CQC website as well. And the rationale behind that is based on what the public need and public feedback. So when looking for a GP provider, they may opt to look at the CQC's rating of that provider and not necessarily read the whole report. So by including the shorter report, the CQC hope it will draw more people to read the report as well. You'll also see with the new framework that it'll be an ongoing assessment of quality and risks. So there won't be a time scale or regular intervals in which they can come and inspect. The inspection can take place at any time. Given you've had an inspection, they can come back again after 1 or 2 months even, any particular time scale. There's no given time scale. They can come back and re-inspect and focus on any of the domains and can be rated again. And that can affect the overall rating if it's changed. And you'll see that the team will assign scores to evidence on a scale of 1 to 4, and we'll have a look at that scoring system in a little while. And that'll be based on the evidence that you can produce, both on site as well as previous to when the inspection has been notified, when you send information through as well. So we'll look at the CQC's 5 questions still. So safe, effective, caring, responsive and well-led. There will always be a focus on these areas and these domains. The overall idea is that an inspection should not be a tick box exercise, but it should be a holistic approach as to whether the service meets the fundamental standards. And these CQC 5 key questions are used to help the inspector assess this. So the reality is that many of these fundamental standards were part of the old inspection regime, and therefore it shouldn't be coming as any sort of surprise. So you'll still be working to produce evidence in all of these 5 key questions. So moving on to the next slide. This is just as a summary here, you'll see the new single assessment framework. So we've got the 5 key questions which will remain the same. So is the service safe, effective, caring, responsive and well-led? The extensive set of key lines of inquiries, the CLOEs, are being replaced by the quality statements. There are 34 quality statements in total, also called the WE statements, and we'll talk about that a little in a little more detail. There are 6 evidence categories, so we're looking still at the people's experience of health and care services, feedback from staff and leaders, feedback from partners, observation, process and outcomes. And finally, there are specific evidence and quality indicators, and these will vary depending on what type and size of provider you are. So they'll be different for a GP practice and a care home provider. So the new singles framework will offer the CQC the opportunity to have an up-to-date view of the quality of the service being delivered by the provider. And the framework will enable CQC to assess providers with a consistent set of key themes, helping them to better identify trends and patterns across areas. So although the CQC will be retaining its 5 key questions of safe, effective, caring, responsive and well-led for assessing services, it is scrapping the underlying key lines of inquiries, the CLOEs, it used to test those 5 questions. So let's move on to the next slide. You can have a look here in more detail at the 6 evidence categories. So we've got people's experiences of health and care services. So if you look in this column, we'll be looking at things like phone calls, emails and feedback on care forms, surveys, interviews with people and local organisations, the survey results, including your Moripol survey, any in-house surveys you may have conducted, staff surveys as well, feedback from the public and service users in the community and voluntary groups, groups representing people who are more likely to have poorer outcomes with protected equality characteristics and unpaid carers. If you look at feedback from staff and leaders, we're looking at evidence from people who work in a service, the local authority or integrated care system, depending on what the provider is. Evidence from leaders, results from staff surveys, individual interviews or focus groups with staff, feedback from people working in a service, and whistleblowing. Here as well, if you are conducting surveys, do look at the findings of the survey reports and make sure that you have an action plan in being able to improve those areas that need improvement. Also looking at feedback from partners as well. So there'll be evidence from people representing organisations that interact with your service. It could be care homes, it could be residential homes, it could be your PCN, NHS England, your federations. How you're working with them, if how your data is compared to the benchmark there in your area, etc. Other organisations you can see can include commissioners, local providers, other multi-agency bodies, depending on the service that you're providing. Again, observation. So observing care in the care environment is crucial. So This is also important when the CQC come to do the on-site visit. So there'll be the inspector and any of the specialist advisors that will be present during the inspection, observing on the day, speaking to the people working in the practice, as well as speaking to the patients in the waiting area, and also speaking to the clinicians and any other members of the team. Processes, so any series of steps, arrangements, or activities that enable a provider or organisation to deliver its objectives. We'll be looking at the policies and procedures, so making sure that they are all up to date, they've been reviewed annually or in line with how often the policy should be reviewed, making sure that it's all up to date, that you've got the review date on your policies and you've got named leads where it's appropriate on the policies as well. And also looking at information from audits, looking at learning from incidents or notifications, and also reviewing people's care and clinical records. Don't forget the CQC will have remote access to the clinical records and your clinical system, so they can go through the searches and also medical records and care plans, etc., as they wish. Outcomes, so how care has affected people's physical or psychological status. Again, here we'll be looking at your data even prior to coming out onto site, your vaccination, your prescribing data, your cytology data, admission rates to hospital, emergency admissions. So there's a lot of other clinical audits that we can look at, as well as national clinical audits as well. So this is all very heavily data driven as well. So do have an understanding of your own data and understand that data, interrogate it, understand any variations, so you have an explanation. But very important is to explain what you're doing about it, if where you need to improve. And then obviously now we're looking at reaching a rating. So obviously the CQC uses 4 ratings to describe the quality of care provided by healthcare providers. So you've got outstanding, good, requires improvement, or inadequate. So to support in making consistent judgments, the CQC will be using a scoring framework for evidence that translates into one of the ratings for the key questions. The CQC will assess the quality of care against required evidence categories based on the type of service being provided. And we will talk about evidence in a while. So evidence could be information already available or actively sought through on-site inspections and observations. The evidence categories are then scored on a scale of 1 to 4. So 4 represents an exceptional standard of care and 1 represents significant shortfalls in the standard of care. CQC will then calculate this as a percentage so that they have a more detailed information at evidence category and quality statement level, and can share this. So in time, this will support benchmarking information. So it's hoped that when this is put into practice at the time of assessment and inspections, this will result in a move away from the previous practice of failings in relation to a particular discrete issue, leading to a provider being assessed negatively across a number of different CLOEs. So we'll see how that goes. So you can see here the percentage for evidence category rating 1 is inadequate, is 25 to 38%. Evidence rating 2, which is the requires improvement, is 39 to 62%. Evidence rating 3, which is classified as good, is 63 to 87%. And evidence rating 4, which is outstanding, is where you achieve over 87%. So here is an example in a little bit more detail here. So to calculate the percentage, you can see here in the evidence category, you've got people's experiences with a score of 3, feedback from staff and leaders a score of 2, observation 3, and processes 3. Now, all of these scores are out of 4. So the maximum score here is 16. So it gives a percentage score for the quality statement of 69%. So you do 11 divided by 16, and that gives you 69%, which falls in the good rating. So this is then converted back to a score and combined with the other quality statement scores to calculate the overall related key question score. And we'll look at that in more detail here. But the percentages on the side here will tell you which category, which rating that score falls into. Remember, the scores are all out of 4. Where it says updated, it's when the CQC have gone in and there's been a change in that score, whereas existing is where they've left it or they've not looked at it or there's no need to have that changed or amended. So here, different quality statements are likely to be assessed on an ongoing basis as the CQC move away from inspecting and making judgments at a single point in time, as I mentioned earlier. So following an assessment, the evidence scoring framework will be used. And this has been developed by the CQC to provide, like I said, a much more consistent, transparent view of quality and determine your rating. So the evidence consists of an analysis of information that CQC already hold alongside their on-site and off-site assessment activity. So the evidence findings will determine the score for each quality statement. So while the quality statements clearly describe the standards of care people should expect and providers to need to live up to, evidence in each required category will be used to assess a particular quality statement. So this means that the scores for different quality statements will be updated at different times, leading to a more current, up-to-date point in time. And it will be a view of the quality at that time. So this may lead to changes in your rating. So review evidence types within the required evidence categories for each quality statement. Apply a score to each of these evidence categories. We'll be combining these required evidence category scores to give a score for the related quality statement. You'll combine the quality statement scores to give a total score for the relevant question, and the score generates a rating for each key question. Aggregate the key question ratings, and that gives you the overall rating. So here you can see in the next slide, I'll give you an example. So combining quality statement scores to give a key question rating. So here you can see that we divide the total. In this case, it's going to be by 21, which is out of a maximum of 32, and it gives you a percentage score for the key question of 65.6%. And this is, as you can see here, from each of those quality statements: learning culture, safe systems, safeguarding, etc. Where the scores are, they've been rated 2 out of 4 for learning culture, for example. That could be because they've not provided all of the evidence in that quality statement area, so they've only scored half the score, so that's only 2 out of 4. So learning culture, for example, things like learning from significant events, learning from complaints, has it been discussed? Are there minutes of meetings? Has there been any changes implemented as a result of this? Are people able to talk about the changes that have been made? Is there a learning culture? Is it a no blame culture, etc., etc.? So in each of these quality statements, you need to make sure that all of the evidence is available for the inspector. All the evidence is actually collated, is concise, is comprehensive. You've got action plans where you need action plans, you've completed risk assessments, etc. So in this total, if you add up all of the areas here, you will see that the score is 21 out of 32, which is 65.6, which falls into the overall rating of good. Right. So these are some of the quality statements you'll see I've listed here. Now, if anyone wants to just participate here, just let me know what kinds of evidence you think you'll be having to show. Now here we're looking at the safe area where we've got learning culture, safe systems, safeguarding, involving people to manage risks, safe environment, safe and effective staffing, infection prevention and control also comes here, and also so does medicines optimization. Can anyone tell me what kind of evidence we're going to be presenting for these quality statements? Feel free to shout out or put it in the chat. Let's see what you can come up with. What kind of evidence?
Policies
Yes.
and audits.
Excellent. Yep.
Risk
Good.
assessments.
Perfect. Now, with risk assessments, we've got things like your Legionellas, your health and safety, your premises and security. So fire, those are just some of them. Make sure all of your risk assessments have been, you've looked at the action plan following those risk assessments, and the action plans are actually completed, and you've got a clear audit trail, and those actions are complete so that you can evidence that. So that you want to make sure you're completing that whole process there. Anything else with regards to medicines optimization? Are we all aware of the searches on our clinical systems, of the searches that we're running? What are we doing in preparation for that?
Rathai, do you want me to read out some of the examples
yes.
people have put in the chat? So
Yes, please. So I'm not seeing
some of the things people put in chat are, in terms of evidence, clinical meeting minutes, staff minutes, monthly journal club for clinicians, minutes of meetings, audits, 360 reviews, re-significant events, meeting minutes and action plans. So obviously people are kind of evidencing that they're reviewing, discussing, considering, prescribing safety searches, MDT meetings and appraisals. So they're the kind of things people are saying.
Lovely. Okay, fine. I'm just going back to my slide here. 1 second. Is there anything else with regards to the medicines management side? Can anyone tell me what kind of searches do you all are you all understanding which searches I'm referring to on your clinical system? 1 second.
Yeah, so just to add to what people have said, DMARDs, presenting safety searches, again, MDTs. So any opportunity where people have taken evidence and reviewed it and tried to learn from it, really.
Okay. So are we all aware of the medicines searches on the CQC searches on your clinical system? Sorry, I'm not seeing the chat, Jerry, so we'll have to just let me know. Oh, I can't hear you.
There's a lot of people put in about medicines, drug alerts, high-risk drugs,
exactly.
CQC safety searches, monitoring.
Yeah. Perfect. So we're looking at those, make sure you're running those CQC searches, because those are the searches that the CQC do like to run as well. That's not an exhaustive list. Make sure you're running your own searches as well, and you're going through your own drug monitoring there. It's really important to make sure that you're delegating, that you're running those legacy safety drug searches as well, so that when we do check those, make sure that they've been actioned as well within the records of those clinical records for those patients. Also making sure that you're doing the drug monitoring as well, and those systems are embedded. So do run through those suite of CQC searches. They're there to help you. There's also those misdiagnosis searches as well, which is really important. So make sure that you're delegating that to your PCN teams, your pharmacy teams if you need to. But there's a whole raft of searches there, in addition to the ones that you should be running within your own clinical systems that you feel appropriate as well. Okay, so again, with regards to the effective, so we've got some quality statements here: assessing needs, delivering evidence-based care and treatment, how staff, teams and services work together, supporting people to live healthier lives, monitoring and improving outcomes, and consent to care and treatment. So again here, do make sure that we're looking at, you'll be providing your minutes of meetings where you've been discussing patients, clinical reception team meeting minutes, palliative care minutes, MDT meeting minutes, PPG meeting minutes, all of these. Make sure you've got the minutes typed up and they're all in one place as well. Make sure that you're looking at your care plans, that they're all being completed as it should be. It's a good idea to just go through your long-term condition care plans, making sure that it's fully complete and it is comprehensive as well, and we've not missed things out as well. So that's a good thing to do and check with your clinicians. What else are we looking at with regards to effective? Can anyone give me more examples here?
Rathai, one question in chat is there a definitive list that people can go to that will give them some understanding of what are the definitive searches?
So the searches that the CQC are looking at, obviously, are those that are already marked as CQC on your systems, whichever clinical system you're using. There is an Arden CQC searches suite there. That doesn't mean that the CQC won't look at other searches within your clinical system. So it's a good idea to just make sure that you're covering all your bases, making sure you're going through your own searches. So no, there isn't any particular guide that will tell you which searches. Those are the general searches we'll look at as well. But we could look at anything. It could be one particular patient, or it could be a discharge summary. It could just lead us to look at that particular patient record. So that's up to you. Make sure you're just going through all of your registers, your learning disabilities, your palliative care, for example, making sure that the documentation is as it should be. Also, do make sure that your systems are working. So your workflow as well. Go through your global view, go through your workflow, make sure you've got tasks, your pathology, everything's being acted on in a timely manner as well. Where you've got PCN staff as well, or nurses, etc., is there a supervision policy in place? Are you documenting that? Is there evidence with that? Is there any learning coming out of it? How are you monitoring and improving outcomes? What are you doing about your data there? How are you improving your cytology, for example? How are you improving your immunization rates, for example? So have an action plan with regards to that, and then see what you can do to improve. But do document that, because evidence is key.
Can I ask something
Yes.
about the CQC monitoring? What are they looking for? Because obviously we're running the searches, and some of those lists require us, the pharmacy team, to be involved and doing something with it. But what are the CQC looking for? Well, like, will they? How do I evidence that we're doing the searches and that it's effective?
Okay, so there's a number of searches in that domain. So you've got some of them are undiagnosed diabetics, for example, CKD, for example. So it's making sure you're running those searches, and where appropriate, they're being coded and then being treated appropriately. So you don't want to have delays in that. Some of them are obviously the safety drug alert searches. So again, you need to make sure you're running those searches and then acting on those where it's appropriate, and coding that in your clinical system as well. Again, when it comes to drug safety alerts, don't just look at this year's, do look at the legacy searches, go back as well, 3, 4, 5 years, whichever. Just make sure you're covering off everything, because you want to make sure the system is embedded. In addition to that, there are those DMARD searches, the high risk drug monitoring. So you want to make sure that, again, you're running those searches and that patients are being prescribed safely, and that drug monitoring is taking place. Blood tests are being taken for patients where it's appropriate as well, in the right time frame. You should have a policy for this, so make sure you're managing that as well. Yes.
So so it's the policy that they'll be looking at, like an action plan for each one, and this is how we are implementing it, and this is there must be a time frame where we run the searches, and that's really the evidence that they'll be looking for. It's like a process map of how we do it. Okay.
So when you're running those searches, you'll see how many patients are, for example, overdue for some drug monitoring, for example. They want to be seeing that you are actually monitoring these patients and that they are being prescribed safely. So you want to make sure that the blood tests are being requested. There's evidence that they're being requested. Where patients are not compliant, what are you doing about it? Is it in line with policy? How are you managing that? So yeah, it's just about running those searches, seeing what numbers, which patients you need to identify that you need to proactively do something about, and then documenting it in the clinical system and showing what you can do. So
Thank you.
Thank you. Those are not the only searches. Remember, like I said, these are in addition. Those CQC searches are picking up the high risk patients as well. Doesn't mean it's picking up all of your patients. So that doesn't negate the need for you to not look at your own searches and create your own searches and run your own searches. There are a vast number of searches on your clinical systems which you could be working through as well. Right, so if we go on to caring, really important here now. So we've got kindness, compassion and dignity, the quality statements here, treating people as individuals, independence, choice and control, responding to people's immediate needs, workforce well-being and enablement. Now, one of the things here with regards to caring is obviously they can see on site through observation how patients are being treated whilst they're waiting, whilst they're talking to those patients in the waiting area. They'll also be talking and interviewing your PPG membership, as well as speaking to your staff and your clinicians. So they'll get a sense and a feel of this caring. And also it's about looking at the patient survey. Now, that's really important because obviously you've got the National Moripol survey, which was published in July this year. And that's data captured between January and April of this year. They'll be looking at the findings of those surveys and where you've got people's responses there, where you're not meeting the target, the actual benchmark, the national levels. Make sure you've got an action plan in how you can improve that. Now, it's really important that you are being responsive here. Even with regards to any sort of reviews or feedback you're getting online, are you responding to them? How are you feeding back? So being responsive is really very important with the CQC, and that is something they do look at, take very seriously as well. Also looking at workforce wellbeing. So have you done a staff survey? And don't forget, we've got this workforce wellbeing agenda now as well. So what have you done with regards to workforce wellbeing? What's the evidence you're going to be showing there? What's happening? What is the feedback you're getting there as well? Again, those people where you've got to consider deprivation of liberty safeguards, where you've got Mental Capacity Act to consider, make sure that's all documented appropriately in the clinical records where it's necessary as well. And again, responding to people's immediate needs. How are you evidencing this? What kind of needs are you having to respond to? What are you doing about it? So it's all about evidence. So do make sure you are looking at all of these quality statements and providing as much evidence in each of those areas. Again, care plans will be one area that we will look at, for example. So looking at your long-term conditions, looking at your dementia register, your palliative care register, what are you doing in order to support those people to live a better life? What are you doing? Are you listening to them? Does the care plan reflect the desires and choices of the people that are using these services, etc.? Just moving on. And again, as I mentioned, responsive. So we're looking at some of the quality statements in responsive are person-centered care, care provision, integration and continuity, providing information, listening and involving people, equity in access, equity in experiences and outcomes, and planning for the future. So again, here, just think about what are you doing with regards to your end-of-life patients, for example. How are they being managed? Are their wishes recorded and actioned? Are their DNAR forms scanned and completed where it's appropriate, for example, and best interests being recorded as well? Again, regular meetings with people that use services. So again, to get feedback, is there any newsletters that you're doing? Are you encouraging feedback? What are you doing with regards to any sort of in-house surveys and results with that? What have you done with your PPG? What are they saying? Again, complaints policy as well, and meetings and agendas as well. Look at all of that, make sure the evidence is all there and collated. With regards to complaints, for example, don't forget this is one of the documents that you'll be expected to send to the CQC when you've been notified of when the inspection will happen. So there is a number of documents that you will have to prepare and send through to the CQC probably about 7 days after you've been notified and before within that 2-week time frame before they come out to inspect. Some of those documents does include your complaints log. Some will be a significant events log. And don't forget, you want to send everything together. So you want to make sure that you've got your minutes of meetings as well attached. You've got the learning from these events and complaints as well as evidence in those tables as well. So that's important to send too. We also do ask for things like your training matrix as well for all of your staff. So do make sure you've got that table prepared and there's no gaps there as well. So there's a number of documents that I will talk about in a while that you will need to be sending to the CQC when they notify you of the inspection. And well-led. So if we look at the quality statements here for well-led, we've got shared direction and culture.
Rathai, just in my role as your timekeeper, so we've got about 5 minutes left in terms of a presentation, just so you're aware of that.
Just to, thank you. Just got 2 more slides here. Okay, so we've got well-led, we've got shared direction and culture, capable, compassionate, inclusive leaders, freedom to speak up, so whistleblowing policy, workforce equality, diversity and inclusion, governance, management and sustainability, partnership and communities, learning, improvement and innovation, environmental sustainability and sustainable development. So here again, make sure your statement of purpose is reflecting what your service is doing, make sure it's up to date. There should be a clear leadership for the service. There should be a clear vision, making sure there's a really good positive culture being established as well. You would want to see things like business continuity plan here, equality policies, for example, as well. Make sure they're up to date. Make sure your business continuity plan, it has got the correct contacts, it's been reviewed within the year. Make sure you've got a business plan, for example. Is there a risk register for the practice? So there's some sort of governance there. So these are some of the examples we'll be looking at. Again, an up-to-date complaints policy, make sure it's transparent, it's accessible. Again, a whistleblowing policy, a duty of candor policy. So these are just some of the things, again, that we'll be looking at there. Recruitment practices, make sure that they do value diversity, people are supported, you've got your suite of HR policies, procedures as well. And make sure that there's a clear structure and staff know who is responsible at all times, and that the risks are mitigated, there are risk assessments, etc. There are job descriptions, there's rotas, for example, supervision policy, etc. And again here, just another slide, how you do it. So the evidence for well-led, again, make sure that the things I've just mentioned are just some of them. Make sure that they are kept in one organized place so that when you do need to access it and you need to show them or evidence them or send it, it's easy for you to do so. So some top tips here. I would recommend mock inspections. It's always good to have a look at the practice with fresh eyes. Embed systems and processes. Delegate. Obviously, it's important to delegate where you can because it is a lot of work to be done, but also you've got various people taking responsibility and it's nice to share the load. And also the CQC do like to see that everyone's got a role to play here as well. So it's not just managed by 1 or 2 people. Have oversight as a registered manager. So if you're the registered manager, make sure you do have oversight, that you are seeing the evidence as it should be presented as well. So you are aware of everything and evidence. So evidence is key for everything that we've spoken about and all of the evidence categories and quality statements. You do need to have robust evidence and audit trails. And then again, preparation, I say, is key. If you need help, ask for help and be prepared. Have a team meeting, discuss what everyone's going to do, have a clear plan, etc. And yeah, that's it from me. So if we have any questions, I'm more than happy to take them now. Jerry, is there any questions?
Jerry, you're on mute.
Can you hear me now?
I can hear you.
Marvellous, marvellous. Just a couple of points before we move into the facilitated questions. I know Susan has had a hand up since the beginning. Is that to ask you a question, Susan, or was that just an erroneous clip?
No, I think I was just messing about with the things at the top.
Okay, no worries.
Sorry.
You found the key to put the hand up, so well done to you. Also, it proves that every day is a school day in general practice, because in chat it would appear that Laura has had a power cut partway through the presentation, and she's asking, will there be a version of this available on YouTube? I think our intention is to put an edited highlights version of the presentation on YouTube. So if you've missed anything, don't worry, it'll be available to either view, or, as I think we've reiterated a number of times, we'll send out a summary document. So a number of people are asking, can they have slides? Unfortunately, the answer to that is no. And it's no, not because we don't want to be helpful, but we think slides by themselves aren't as valuable as a comprehensive document that kind of summarises the content, answers the questions that were asked during the session, and also includes questions we weren't able to cover in the session. So we think we can do better than the slides, and that's what we'll make available to you. Okay, so that was just my little catch up. There have been quite a few questions asked as we've worked our way through it. So a couple under the heading of safe. One I thought was of real interest. Obviously, lots of practices have people working on their premises who they don't line manage. So they have PCN staff based in their organisations. How do they evidence kind of that they're being responsible in terms of those individuals? Any thoughts on that, Rathai?
So if it's PCN staff that are working in your practice, I'm assuming that's what you're asking.
That's what we're asking.
So yeah, so we may have, obviously we've got a number of ARRI staff, such as paramedics now, pharmacists, physician associates, to name a few. So it's really important, for example, with a pharmacist that's working, you'd want to audit. So it's a practice's responsibility to audit that work, supervise them, make sure that things are being done as they should be done. They are in effect seeing your patients, you are delivering that service, you're responsible for that. The HR may be the responsibility of the PCN, but the actual work itself and the consultations, for example, you would want as a practice to make sure that you're auditing as well and feeding back. You may have an agreement with your PCN on who's going to do that, or a designated person on who's going to do that. But the point is it's happening, and you've got evidence to do, and there's a learning culture there as well with regards to that again. So that's important that the practice also carries that work out. Yeah.
Do you want to stop sharing your slide, Rathai, and we'll just answer the questions as they come up? Is that so? There's another question leading on from that in terms of, will PCNs be inspected individually?
PCNs being inspected, I don't know the answer to that one, whether they'll be inspected individually or not. I'm assuming so. I don't see why not, but we'll have to watch the space for that.
Okay, well, that's definitely a reflection of this is work in progress, isn't it? So we're in the rollout phase, so all these things will become a lot clearer as time goes by. Some of the other questions that were submitted around SAFE again. I'd like to find out about CQC monitoring. What are the CQC looking for in their reports? What should we look for? How do we present evidence for these? And that was asked by Madhu and Barry. So any thoughts on that?
With regards
I think you've just mentioned that, haven't you? Yeah.
Okay.
I think the lady asked that question. Is that right, Madhu? Yeah.
Okay, sorry. Is there we've done that one as well. So under the well-led heading, someone was asking about, we used to have quite an active PPG. Since COVID, no one is coming forward to join meetings. I have put notices for new members to join, but no response. What would you advise?
Okay, so if you're not having the conventional face-to-face PPG meetings, it's a good idea to at least try to gauge feedback either virtually as well. You could be trying to encourage membership for your PPG. I think that is a good idea to keep trying to try see other ways of doing that. But virtual feedback is also another option in the interim. It's important to just be responsive and to just try and seek feedback, and that's what you want to be doing really. You might want to send out messages to certain cohorts that you feel you feel that you need to reach out to as well, using your text messaging services. It's just doing everything you can do, even outreach work, going out to places where you can reach these people as well is another option as well. You've got to be trying to do something rather than just being complacent about it, even though it is quite difficult. I get that with the PPG now, but even Teams meetings with PPGs is another option as well.
Okay, it's a very precise one. Do we have to have Legionnaire testing if the water is coming directly from outside mains and not from a tank, and the taps with it in the surgery are run Monday to Friday for 4 to 5 minutes during the day? What a precise question. Rathai.
Yeah, I think if it's mains linked, I'm not a Legionella expert. I would recommend that you ask that question. Either you can ask that question directly of the CQC as well, but do check what risk assessment has been done. It's obviously employer liability as well, so it's important to know the risk of Legionellas in a building. So I wouldn't specifically advise on that. I would ask you to consult Legionella experts and even seek guidance from CQC on that one directly.
Okay.
I've got 2 questions here, Jerry, that I was going to put together. So
yeah,
one, somebody asked early on actually, is there a definitive list of how often each policy should be updated when there is no major update? And another question about policies, do you need separate policies if everything is already included in your staff handbook?
Policies, usually the CQC will not advise how often you should be updating your policies. Generally speaking, they're annual updates. If your policy is stating it's not to be updated for 2 years, well, then that's fine. It's not updated for 2 years unless there's any changes made, I would say. The important thing is that everyone is aware of where the policies are and they are up to date and they're relevant and obviously customized to your practice. What was the other question you asked me, Helen?
Do you need separate policies?
Oh, yes.
If everything is already in the staff handbook?
Yeah, the staff handbook, if your employees are signing off that they've read the staff handbook, that's fine. When you're updating a policy, how is that information relayed to your staff, for example, for HR purposes? Some policies are very long. It's not practical for everything to be in a staff handbook. So I wouldn't recommend that. I would think that you would have specific policies for certain things, depending on the importance of it. And, just the basic ones in the staff handbook, I think is more appropriate. That's my personal opinion.
And obviously we've got SPM Core that could help with that. So Nina Jenkins, it was you that asked that. We can send you some information about that if you'd like us to.
Yeah.
Do you want me to read the next one? So someone's just put in chat. Can we see the list of CQC documents that will be requested 7 days after being notified of a visit?
Yeah, so this varies from inspector to inspector. If I just tell you verbally, so some of them, normally it's, as I mentioned earlier, the CQC, the complaints log, and that should be a concise document with your acknowledgement, your responses, if it's upheld, etc. Also, we want to see the learning and minutes from that. So minutes of all of your meetings for the last 3 months, possibly. It could be longer. You want to include your training matrix. So if you're using any sort of provider platform, you want to make sure that you can get that training matrix for all of your staff. So all the training to be in one place, collated in one place. I believe Thornfields has something for that as well, don't you, to use? Also, you want to send your HR policy sometimes. They may ask for that as well. That's your recruitment policy. Also, your significant events log. Your fire risk assessment is something that's also asked, and also your infection control audit as well. Now, don't forget infection control audit with regards to NHS England timelines, you need to be doing that twice a year. Now, when you send these risk assessments, that's your fire and your infection control, you want to make sure that you're also sending the action plan. And the action plan is what's important because they're looking at your action plan. Also, any in-house surveys is important as well, and an action plan with regards to that. And also the action plan with regards to your Moripol survey as well. Is another document that you want to be sending to. So those are just some of the things at the top of my head that will be requested. But don't underestimate the time it will take to prepare those documents and keep that in a place that's easy to be retrieved. And you may have to send it through it as a couple of emails because it could be quite a large document to send through in one format. So just beware of that as well.
I mean, I suppose my observation, one of the things that Thornfields and FPM offer is kind of a critical friend assessment of where an organisation is and where they need to be to meet CQC standards. And when we've done this in the past, one thing that has kind of stood out is people make a paper commitments, but then don't cascade awareness of that or do that activity as they committed to in the piece of paper. So, for example, people would say that their health and safety policy said that safety incidents would be reviewed quarterly at a partners meeting. But then when we reviewed the partners meeting notes, no review happened. So for me, that's the really, really key. You can't just comply on paper. You have to comply in reality.
Yeah, absolutely. And I think what's really important, and this is the observation side of things, is when you have a policy and the policy states that you're doing something, you want to make sure that it's actually happening on site and the evidence is there to show that. Also, having these systems in place, like, for example, a 2-week wait log for your 2-week wait log for your cancer referrers, for example. If you've got a policy with regards to your 2-week wait log, then you've got the evidence to show for that. And if we go and randomly check things, there is a safety netting happening as well. And don't forget, there are searches on your clinical system for you to check this as well. So make sure the policy is actually working. And that's crucial, as Joey's just mentioned. Yeah.
Okay. So we're just going to wind up in about 3 minutes time, but anyone who can say 2-week wait log on a webinar is doing well in my book. So a couple of people have said the audio has been a bit suspect at points. So I think, Rathai, you mentioned the survey. Was it the Ipsos survey? Just so
yes, it is the Ipsos
Moripol.
Yeah, it's the Ipsos survey. It's not only important to look at, so if you've not had an inspection for a couple of years, for example, if you've not had the CQC come out a couple of years, do look at your surveys. Make sure you have an action plan, that you're dealing with those areas where you need to improve, and you can evidence that. That's really important. You need to be responsive, and that's one way of doing it. One of the other things you could be doing is designing an in-house survey to also complement that Ipsos Moripol survey. So where you need to make improvements, you might want to pick out those areas where you need to improve on and create your own survey focusing on those particular areas, so you capture real-time feedback, and that will be your action plan as well.
Just probably the final question, really.
Let me just go back a little bit, because I think just answering Laura's question there. Okay. If you type in National GP Survey in Google, you will find your Moripol survey. So that's just a quick tip. Just type in National GP Patient Survey and type in your practice name. It will come up with your survey. You can then go through the survey, discuss it with your PPG members, your staff, create your action plan.
Probably the last question then is, does CQC have a bad or good practice shared learning examples for each of the topics?
Yeah, that's a good question. The only thing I would advise is, no, not really. But what you can be doing is going and reading reports that are published online. So where you've got outstanding, good, requires improvement, if you read those reports, those narratives, you will have an idea of where practices are doing well and where they've not done so well. So those examples are just published through those reports.
Okay. Well, I think we've run out of time, Rathai. That was really informative, helpful, and thanks to everybody who got involved. That was really appreciated. So I'll just say a few words just to wrap up the session. I hope you found it helpful. I hope you found it informative. Again, I think my colleague Helen is going to put in chat the link to our feedback form. If you could fill that in, that would be really, really helpful. I think the sense is that we'll follow this up with an explanatory document that will summarise what's happened in the session, questions asked, and also questions we weren't able to ask. Our intention is to run another webinar round about mid-February time, and that will be very much experience-based. So by then, people will have experienced what SAF is like on the ground. We'll look to plug into that experience and share that experience with people who join that webinar. So, you know, keep calm, watch this space, look out for further webinars from FPM. So I suppose all that is left for me to do, according to my advent calendar, there's only 3 days left to go to Christmas, but I think in reality, there's about 19. So if you've joined us today, I hope you enjoyed it. I hope you have found it worthwhile. And I hope you're looking forward to Christmas. And I hope we can all look forward to a great 2024. So take care of yourselves. And hopefully we'll see you on another webinar in 2024. So goodbye from me.
Thank you.
Thank you. Jerry,
Bye.
we'll just leave it on because there are still people asking things, so I'm just going to reply to them while we're doing that.
Okay.
Hang on. So somebody's just asked about when will the summary be sent out, and I've just said once it's been updated with today's questions.
Okay.
Helen, could I ask a question? Is that okay?
Yes, of course.
I put it in the chat, but I just wanted to ask about the IPC audit. I think on a previous webinar that you did, you mentioned something about NHS England have a audit, but I'm not sure where that is, and that's the one to use. Is that correct?
Yeah. So there is an NHS England infection control toolkit. If you don't have it already, I mean, I'm more than happy to share that. That's a standard NHS England toolkit. It's a very good comprehensive document with lots of hyperlinks. Great to be used as training as well. And that's the tool that they use when they come out to do your infection control audit. So rather than use anything else, I find it easy to use that particular one because it's looking at exactly what they're looking at, and it's a very comprehensive document. If you want that information, I can share it with Thornfields and they can send that out to you, Helen, if that's okay.
I'm starting to sound like a broken record, but we can put that in our summary document, can't we?
Okay, perfect.
We'll just make that the go-to document for this topic, I think.
Yeah, we can attach that in there then, Jerry, a template for that, and then yeah.
So I wasn't certain who asked that question. Are you okay if we do that?
Yeah, that'd be brilliant. Can I just do a follow-up to that? Sorry.
Yeah, go for it.
Would you recommend like outsourcing companies to do things like IPC or health and safety for GP practices because of the expertise, especially with health and safety?
Yeah, that's something that I wouldn't advise on. That's absolutely your decision, and yeah, it's all about employer liability. It's making sure that you don't miss things. So I would say it's a sensible thing to do, and make sure that you've got everything covered, especially when you're in a big premises or, you know, there's many floors, etc. It's not just, you know, so it really does depend on the practice. But yeah, I don't see anything wrong with outsourcing that, as long as the main thing is that it is done appropriately, it's done correctly, it's a reputable company, and then the action plan that comes out of it is followed up and completed.
Brilliant. Thank you for your help.
You're welcome.
There's still quite a lot of people on. Has anybody else got any questions? We can, Rathai, have you got to be away?
No,
or are you happy
absolutely.
to hang back? Yeah.
More than happy to take questions.
Yeah. We might as well hang back and see if anybody wants to ask, because there's still 40-something people online.
Hi, there was another question just about, so in our ICB in the Midlands, we don't have a occupational health provider.
Yeah.
So we're having this thing now for quite some time. Actually, the provider that they provided for a short time was about over an hour away. So it's kind of like, how do we mitigate any issues there, especially when it comes to the CQC checking staff files, etc.
Okay, so we have the same issue actually in my patch, and we've not had that as well. One of the things I would say is with regards to your NHS England infection control, they are expecting you to have your blood immunity test done, the actual blood test results being shown, not just a tick box to say what vaccinations you've had. So we've done our own in-house phlebotomy, and we've done it in that way. Where you haven't got the occupational health provider, I would obviously escalate that where you need to escalate it, try and find out where you can get that provision being made. If it's an hour away, that's something maybe you want to just take up and see if there's any other options for you available in that ICB. The important thing is to have an audit trail of those queries and who you're escalating to and what the responses are with regards to that. It doesn't take away the need to check your clinician's immunity status for the HR files. That is crucial, it's important, and that comes down to employer liability as well. So that's a decision you have to take as a practice, how you're going to do that, or where your staff are going to go and get their bloods done. But that I wouldn't, it's quite important to make sure that's there in the file, because again, if you don't have that covered off in your infection control, that will come out as not being 100% in that area. So that's quite important. But at the same time, I would have conversations with the ICB to see where you can get your OH provider, and if it's far away, then yeah, it's a discussion that'll have to be taken really outside.
At the moment, there doesn't seem to be any offering whatsoever, so there we could just do private and that ticks the box and we move on.
Absolutely. I would say so, especially with employer liability. You don't want to have issues going down the line without, not having tested that. And risk assessments are all well and good for the non-clinical staff if they're not. But when it comes to clinical, no, not worth the risk.
Right, thank you. Thanks again.
No problem.
Helen, I don't know whether you want to pick up the last question in chat about kind of assessments. Obviously, we can do that. So if someone is interested in that, they can just, contact us and we can help them with that.
Yeah, so we can offer that service. Is it Naeem? We can offer mock visits, or we call them, what's the word, Jerry? Begins with an R. Readiness appraisal. We call it a CQC readiness appraisal. So we'll help you, look through everything that you need, everything that you've already got, things that you might be missing in terms of policies and records and how you're going to provide the evidence, and also help you identify areas where you might be considered outstanding, just to make sure that you shout about those from the rooftops, really. So it's a good overarching view of what you've got going on in your own practice. And we can help with that.
Yeah, thanks for that. It's Junaid. But I was just going to ask, sometimes with these types of services, it's good that you could identify what's missing, but then it's kind of like having the time to then do it. I know it sounds petty, but it's just, do you do a bit more than just say these things are outstanding?
You mean do it?
What we can't take is the responsibility for the action plan. So we can help you put together an action plan and we can help you prioritize that. But actually turning it from a paper to-do list into a reality, that has to be the responsibility of the organisation. So
sure. Brilliant.
I don't know if that answers your question.
Yeah, it does. Thanks.
I think following on from the outsourcing of occupational health, I think someone thought those answers were pitched particularly at clinicians, and they followed it up with, what about non-clinicians?
Non-clinicians, with regards to blood test immunity, you want to be having, if you don't have one of your staff vaccinated, for example, or you don't have anything on record for them, for example, you would want to make sure NHS England would expect to see a risk assessment for that. So that should be in the file, in their HR files as evidence. You have to risk assess that person particularly, if they're handling specimens, if they're handling spillages, etc. Anyone can have a needle stick injury. So that's something that the practice will have to do as a risk assessment, but it should be documented.
Okay. I'm just following up from, I think someone asked about outsourcing health and safety to a third party. Obviously, we're a training provider, so we can help you develop your in-house resource to have that objectivity to risk assess the situation and then put mitigation in place. So if you want to grow your internal people as opposed to bring in third parties, then you may want to have a conversation with us about developing people in terms of health and safety and risk assessments. I think there's still quite a few people on the call. Obviously, we'll stay on the call as long as it's helpful. So if people have questions, if people have just forgotten to log out, that's absolutely fine. But if people are still logged in with a view to participating, then feel free to put some questions in chat. Obviously, if things go absolutely quiet for the next 5 minutes, we'll assume that people are logged in by accident. So if we're happy to stay here, but obviously we can only answer questions if we're asked them. So if people either want to speak or pop them in chat, we'll take it from there.
The person who was asking about the non-clinicians for the immunity test and things, they said that they had staff in the past refusing to cooperate.
Yeah, so then in that case, yeah, as long as it's documented and there is a risk assessment and signed and in the files, there's no more that you can do. So yeah, with non-clinicians, I think that's appropriate. Just be careful when it comes to spillages and who you ask, who you're exposing those sorts of incidents to, though. Bear that in mind.
I mean, the other thing I think is probably worth a mention while people are on the call is that we've just updated our kind of workshops in terms of raising awareness of SAF for both the leadership team and the teams themselves in practices. So if you want to grow an understanding within the organisation, you may want to send either your leadership team or the full team on a course that helps them understand what the SAF is about, how to collate evidence, because I think one of the messages that came out from Rathai loud and clear, and actually came out from a senior partner I used to work for, that if there's no record of it happening, it may as well never have happened, because when you are assessed, if you can't demonstrate proof that it happened, then it may as well never have happened. That meeting, those minutes, that review, that MDT.
I've got a slightly ridiculous question again. So, so like with that measles outbreak that happened fairly recently, at least in the Midlands, there was like a big push to get everybody vaccinated in the practices, especially, and a lot of the staff don't want. So, or they say they've had whatever they've had, but you can't prove it because they're 50 years old plus, or whatever it is. Their records are not. They're not great. So they're apart from risk assessing those staff. Like, what could you do? Because it still leaves you open, but you can't force them to have a vaccination.
No, I think it's just informing, giving them. It's about informed consent, isn't it? They need to have the information, the risks of what can happen if they do contract measles. I think just giving them that kind of information that you would give to a patient, for example, that's all you can do, and then document that. We can't force people, but as long as they've been informed and then they've signed and that risk assessment is complete, there's no more you can really do. It's patient choice.
That's brilliant. That's the answer I was looking for. Thank you.
No problem.
So there's another question in chat. We meet weekly with DNs and have regular SEAs and safeguarding meetings and PAL care meetings. Not really sure what we can minute other than saying we discuss patient cases. So what can they minute? Still respect confidentiality and yet evidence that it happened.
Yeah, absolutely. It's got to be, these are going to be anonymized minutes when you send them off anyway. It's just about learning. It's about peer review, if it's clinical meetings, even clinical audits. It is important, where you've discussed that, as well as even quality improvement projects. That's another thing that they'll be looking at, is quality improvement projects, and what kind of work has been done. With regards to minutes, just make it comprehensive. You can have a standing agenda for some of these minutes, but the clinical is about, what's been done, what's, the integrated working, are there other teams involved, etc. Anything that needs to be picked up clinically. Just document that.
And also you can have some kind of cross-reference, which is what someone's put here. We record on patients' notes and refer to it in the minutes. So that is
exactly.
It's not exposing anyone's identity, is it?
No,
Overtly.
absolutely not. No. But one thing I would mention is making sure that you do have quality improvement projects and in the pipeline if you haven't already. That's another thing that we are looking at. The CQC do look at as well as the clinical audits.
Is there a list of good quality improvement exercises for practices, clinical and non-clinical?
There's many. This is also practice specific. If you find that maybe if you want to increase your prevalence somewhere, or maybe there's an incident that's happened, that could also trigger you to look at that in more detail. It could become a quality improvement project. There's a load of ideas with regards to quality improvement projects. Even things like resuscitation audits, cold chain audits. It's anything. The list is endless. You can
But
just
also, I
search
really
those.
like your point, Rathai, about it being patient-led.
Yeah.
So if you took as your source document the most recent patient survey, or a survey of your team, or
absolutely.
some ideas, ideas from your PPG. I mean, an improvement project is just, we think we can do better activity X. This is what we intend to do about activity X. So you measure it at a baseline, you then do the change, and then you measure it after the change to see whether an improvement's happened. And that's how you demonstrate we understood we could improve, we tried something and we have improved, or maybe we haven't, so we'll try something else.
There are a list of improvement ideas on the RCGB as well. At the same time, even when you're talking to your clinicians in a clinical meeting, for example, ask them, what have they got any PDP plans for their appraisals? Is there anything they have a particular interest in? B12 injections, for example. It could be anything. Ask your clinicians what they'd like to look at. Even the Z drugs, for example. Is there something you can do to improve quality there, or patient outcomes there? Even with regards to your survey, if you've got access as an issue, you might want to do an access audit, for example, or a telephone audit, for example. So you could literally come up with anything. I would look at those areas where you need to improve, and that's practice specific, and then discuss with your team, what do we want to do here? What do we want to improve here? And then look at the data. The point is you've done something, you are doing something, you're being proactive about it, and that's what's key here.
Okay, then here's another one. Are the CQC clinical searches on the different suites reviewed to see if they are correct and updated regularly in line with what they are looking at?
That's a really hard question. Okay, so those CQC suite questions is obviously put on there by Ardens, and that's who CQC have partnered with to do that. Absolutely, I would think that it is. From my understanding, they are up to date, and they do get updated as and when they should be, in line with guidelines. That's their job. So yeah, I wouldn't think that's an issue. Like I said, those searches, it's not exhaustive. You also need to complement that with your own searches. So don't just rely solely on that. I would complete all of those searches and do all the work that comes with all those suites in that CQC folder. But there are other searches that you could be running as well, and doing.
We use System 1 and they are Arden copies, hence my question.
Yeah.
I think they're on version 2.3 at the moment, so they do definitely update them
Yeah.
from Ardens, and they're available for everyone.
Yeah.
That's great.
There's a lot of work there as well. So do you delegate that work?
Yeah, I was just going to ask on those searches. They're divided between, I think it was standard and enhanced.
Enhanced, yeah.
So are we focusing on standard first, or
you can do?
Yeah.
It really depends. The idea is to complete all of those searches in those folders, but it's whatever time allows and time permits and resources as well. So it's important to go through all of them eventually. But yeah, you can start with whichever really. I mean, ideally, you don't know which particular one they're going to run on the day. It could be any of them. So you could be unfortunate if they, find something that you've not picked up on. So it's a good idea to just complete them to be
brilliant.
safe.
Thank you.
Yeah.
Can I just apologise to Thornfields as well? So at the end of the presentation, I thought we were finished. So I started completing the feedback, and I put not enough time for questions. So please ignore.
No worries, we accept your apology. Thanks. It's probably my fault anyway. So sorry
totally
from
my
me
fault.
to you. So thanks for sticking with us anyway.
No, thank you. It's been it's been
They're
really
great
good.
questions. They're great questions, Janae.
Yeah.
It's been really useful. So thank you.
All right, welcome.
You're
Well,
welcome.
thanks for your time. Take care. I think what will be really interesting is as this unfolds. So, in March, when people have had real experience of this, what does it feel like on the ground?
Yeah.
Because things always look different when you read it in paper. That's what it's going to look like. But what does it actually convert into?
Yeah.
What does an assessment feel like?
Exactly. I shouldn't think it feels so much different. I think what's important is the amount of evidence that we're expected to collate and have, and it's the quality of the evidence and the completeness and thoroughness of that, which is going to be crucial, really, because it's a scoring. Because if you're once you're rated with your scoring, we can see how far off you are from a good to a requires improvement. It'll be very specific, even though that percentage won't be published. That will be known to the practice, so you'll know how far off you are, and eventually the public will know that as well once that sort of rating is published and that information is published.
Which is really helpful, isn't it? Because previously you didn't know, were you within touching distance, or did you just scrape through, or were you just on the edge of outstanding?
Yeah.
So that's really helpful in terms of calibrating.
Yeah.
What additional activity do I need to put in?
Yeah.